Thank you very much for joining us. Borders closed, schools shut, social contact discouraged. Countries have been taking extreme steps to control the spread of COVID-19, this coronavirus. Here in the UK, there has been some criticism that official action's been too little, too late. Are governments getting this right? You're watching Roundtable. Very good to have your company. I'm David Foster. Many countries have not seen the like of this in peacetime. Unprecedented action to stop the spread of this terrible new virus. France's president likening it to a war, and he's not the only one. But in some countries, there are questions about the battle plans.
After its beginnings in Wuhan in China, Europe is now the epicenter of the coronavirus outbreak, and governments have been scrambling to respond. The EU closed its borders for 30 days. Sweden and Germany announced school closures. Spain and Italy have been on lockdown, severely limiting travel and asking people to stay indoors. France, too, has restricted people's movements outside the home. In the UK, the Prime Minister has asked people to limit social contact where possible and avoid gatherings and crowded places.
Now is the time for everyone to stop non-essential contact with others and to stop all unnecessary travel.
The UK government took action after being given a projection the country was on course for a catastrophic epidemic, with up to 250,000 deaths and intensive care services overwhelmed. But in the UK and elsewhere, it's impossible to know how long the extreme measures will need to last.
Well, I'm very pleased to say that joining us via Skype from Oxfordshire, we have Professor Sian Griffiths, a chair of the Global Health Committee, who is also a member of Public Health England, involved in the current crisis. From Chicago, we say hello to Dr. Jeremy Rossman, Honorary Senior Lecturer in Virology in the School of Biosciences at the University of Kent in the UK. And also from Kent, we say hello and welcome Dr. Bob Gill, Doctor and NHS Campaigner. Great to have each one of you on the programme. Sian, 15 or so years ago, you chaired the official inquiry into the SARS epidemic, severe acute respiratory syndrome, the one that affected Southeast Asia. You were in Hong Kong at the time. What did you say needed to be learned from that?
We looked back over the SARS epidemic and we came up with a set of recommendations. Don't forget, SARS is a bit different from this coronavirus because we didn't know what it was whilst we were dealing with it, the first tranche of actions. And that was because it suddenly came out of the blue. This time round, the virus has been characterized much more quickly, which has enabled one of the criticisms to be addressed because there seemed to be an awful lot of competition between academics. Information wasn't shared between China and the rest of the world, a whole set of issues which made it very difficult to deal with. We learned that the public health system was not adequate. We learned the hospitals found it difficult to cope. Communication between the community and the hospitals was poor, but above all, communication with the public was failing to get the messages across. And I think that, you know, if you look at where we are today in the UK, we've just shifted policy again. We've moved in a way, not to address the criticisms, but we've moved in the way that the criticisms were pushing us to take more rigorous steps to move into the suppression phase. And that's always very difficult to explain. And I think some of the explanation issues are the same as they were back in the days of the SARS.
So in terms of lessons learned, you would say that is one that is being addressed today for the betterment of the public, would you?
Yes, I think the daily briefings are essential. If you don't have the daily briefings, then it gives rise to lots of space for people to come up with misinformation, the wrong theories, with all sorts of issues. So daily information briefings that allow people to ask questions and then the questions to be relayed around the world, etc., makes it much, it is a really essential part. And I think the difference this time around is the use of science to drive the policy. We're always complaining in public health that policy doesn't follow evidence. And now this time round, the evidence is addressing, is leading, is influencing, is being used to make policy.
Okay, Bob, Dr. Bob in Kent, I just want to ask you first of all how you're getting on in your doctor's surgery. You're a general practitioner, family doctor, but I also want you to respond to the suggestions that actually now the government is on the right track. First of all, what's your daily life like at the moment?
Well, we're dealing with a lot of anxious patients and staff. Thankfully, our patients are being very sensible. We've put off routine procedures. We're channeling a lot of work and giving a lot of advice over the phone. So the activity in the surgery has not significantly got any worse. In fact, it's slightly quieter than usual, so that's not a problem. But there are a lot of people who need reassurance. The advice has not been as clear as possible. But in terms of the government reacting to evidence, I don't know of any evidence that said, do not test people. I don't know any evidence that was telling staff who were self-isolating with symptoms, call them back into work and expose other patients to the virus. I don't know of any evidence which said, make sure your hospitals do not have enough protective gear. The problem is, despite several weeks of warnings, the government and the NHS has failed to put in basic steps to ensure staff are protected, staff are informed. They are playing catch up. And
but in defence of the government, which is not my job, but I might as well throw it in here, they weren't prepared. Nobody knew anything about this virus when it first came along, and it is a case of playing catch up because you're never going to be ahead of it.
Well, if we look at government policy since 2010, they've cut 15,000 beds in the NHS. They've engineered a workforce crisis by attacking staff's terms and conditions. They failed to reassure European health workers that their status was safe in this country.
All right, listen, Bob, I'm sorry. I know this is something you feel strongly about, but we're talking about strategies with regard to this particular illness. And I'll come back to you plenty of time during the program. But Jeremy, let me ask you this. There is no right way to say, we've got it cracked. We know exactly what we're doing. Each international plan of action is different because nobody knows quite where to start.
Well, I think that we actually do know a little bit where to start. Obviously, every country is going to be different. Obviously, this is a new virus that we don't know a lot about, but we've had pandemics before. We've had a lot of preparation since the 2009 swine flu pandemic, and there have been a lot of calls for action for preparation that we could have taken and started to take, but have become complacent before this pandemic occurred. So there was more that we could have done in preparation, but obviously each country and each new virus is a unique situation.
Isn't there always more that could be done with regard to something that eventually becomes important, and you have to prioritize? Therefore, you didn't know before this what you now know.
There's always more that you can do, and retrospective analysis is great for informing exactly what we should have done. But there are a lot of lessons that we did learn, but haven't well applied.
Okay. Is that different to the way you see it, Sian, because of what you said at the beginning of the program?
I think, as we would say, the retrospectoscope is a great tool because you can always say what could have been better, what could have been done better. That's the point of looking back and trying to learn. That's the point of audit and trying to learn. But I don't think anyone was expecting to have this virus on this scale at this time. And it's really a question of how you use your resources, how you prepare to use your resources. I would say that having a National Health Service in the UK, we can at least have a nationalised, coordinated response. I don't know if you want to comment on the States, but I think if I was in the US, I would have many more anxieties about how you get the consistency of response, particularly for the vulnerable.
But was the UK government's one? I know you follow it pretty closely because you look at what's happening at these COBRA meetings, these emergency government planning meetings. You are part of public health England. Do you think there was some muddlement there?
I think, as you said earlier, you don't know what you're dealing with. This is a new disease, and we're learning. And I don't know if anyone heard David Nabarro speaking this morning. He's from the WHO, and he was very clear that this is a time when we're all having to learn together, and we don't know what's going to happen. So it's absolutely, I don't think any of us, when we saw the first cases in Italy, would have thought that the Italian explosion in cases would have happened. And we're learning from that.
And I'm going to ask you too a little bit about this particular virus in just a moment. But Bob, let me come to you. You were critical of cuts that have left a health service or a public health service system in such a state. But let's just get to the point about the government's response to this one in particular. There's been criticism that there was a suggestion that upwards of 250,000 people in the UK could die, maybe many, many more than that, before there was something called herd immunity. Now, that was a mistake by somebody saying that, and the government has got out of its way now to say that wasn't what we meant at all. We said it could be a possibility that it follows. It is not our strategy. So for people to bang on, perhaps, about the government saying, you know, we're going for herd immunity, that's irresponsible too, isn't it?
Not at all. It's a description of what's taken place. So first we had the flights back from China, which they dealt with significant caution. They quarantined them, they took them over to Liverpool, and they had protective gear. Funnily enough, they'd never gave protective gear to the driver of the coaches that went
Well,
up.
I'm going to say that the drivers declined to wear it. I have to say that.
Then we had a completely different approach when people were returning from Italy, when they came back and weren't given any advice whatsoever. If you look at the WHO's statement yesterday, 3 words: test, test, test. We have not done that in a consistent fashion. We continue still to not do that. We're not even testing staff with suspicious symptoms, and we're calling back staff who have symptoms to work on overstretched wards.
But do you think it would be wise to test everybody who said, I'd like a test?
Yes. They'd like a test.
Well, what if they had a test and it was negative, and the next day they came back saying, actually, I don't feel well today, I'd like another test? You cannot do it that way, can you?
In my experience, that does not happen. People are being refused tests who've come into contact with people with symptoms, or they have symptoms themselves. And if the government wants an accurate picture of what's going on, you test frequently, and you test widely. You do not operate blind, and that's what they've chosen to do. That's been government policy, to go blind and let people get exposed to the virus.
Okay, Jeremy, and then also Sian, if I may. This is a very different virus to many that we know of and are pretty familiar with. I mean, flu and measles, I'm no doctor, I have read, are carried in an airborne fashion. This is carried via droplets. Because it is such a clever little old virus, is there any way that testing on a massive scale would be, first of all, you, Jeremy, the right thing to do, as Bob suggests?
Absolutely. I think not only is this the right thing to do, this is the necessary thing to do. If you look at the messaging that's coming out of the World Health Organization, it is extremely consistent and has been for a long time. There was a great quote that said, "You cannot contain a virus if you don't know where it is." We need to be testing at a large scale, and we're not doing that, because otherwise all we can do is really delay the spread of the virus, which is still a useful strategy. But if we don't also employ containment measures that rely on testing and isolation, we are never going to be able to.
Is it a practical response? It may be the response you want in your heart of heart and medically also, but is it practical? 60 million people in this country, approaching 300 million in the United States. Is it feasible?
It's very difficult, but compared to the feasibility of overburdened NHS, of massive requirements for ventilators, of many deaths, it all has to be taken into context. It's a very difficult thing to do. It can't be done immediately because the availability of tests needs to be scaled up. Maybe even we need more rapid diagnostic tests that people are working on right now, but it is possible. And in context for what's going on with this pandemic right now, it's necessary.
Sian, I'll come back to you in just a moment, but Bob, let's say you did massive testing such as this, and in the course of 1 week you discovered that, let's say, 3% of the population was infected, which is a possibility. Then that's close to 1 million people. What do you do with all of those people? Do you find places to put them, to isolate them? Do you tell them to go home? There's a social issue to this as well.
Sure, we do not have to reinvent the wheel. We just had to watch and learn from what China did. They had fever clinics set up in the community. People suspected of coronavirus were sent to these fever clinics. They waited there. They had the test down to 4 hours, PCR testing, which could identify the virus very accurately. And if they were found to be positive, they were put into hotel rooms or other accommodation with other positive patients, so they were not contaminating their families. The biggest mechanism of spread of this virus is within households. 80% of contagion is within households. Our government is saying, we won't bother testing you, go back and self-isolate with the rest of your family.
Okay, I'm going to go to Sian. I'm going to go to Sian because she hasn't spoken for a while. First of all, tell me what you want to tell me, and then I'll ask a question.
I was only going to say that I think that's a misunderstanding of the government's policy on testing. The testing at the moment, because of the limited numbers of tests, is being prioritised for those who are sick in hospital, to identify those who need early treatment so that they can have the treatment at the right time, and that will save lives in the longer time. It's important that ITU patients are tested, and it's also important that patients who have phoned 111 after being sick for a week can get the test. We are limited in the tests that are available at the time, which we've already heard. We don't have the tests to do it. Public Health England are increasing the number of tests that are going to be available, and also moving towards a serum test which will look for antibodies, which will give the right answer to how many people have been infected. This disease does not manifest itself in everybody. A lot of people have silent disease. 80% of people have a disease that doesn't require them to actually contact a healthcare professional. So I think the issue of testing is yes, we should have the tests, but it's not the only thing we need to be doing, particularly at this current time when we're facing an explosion in the disease in our community.
Help me here as a layman. You talk about the discovery of antibodies. Would it be more helpful to find them in people who've shown very few symptoms?
Exactly. Who has had the disease? Who has been exposed? And you only do that by doing community serology after the. Actually, you can do it as you're going along, but often it's after the event you can find out how many people were in fact infected.
And in the hunt for an eventual vaccine, which we're told even with the best will in the world is going to be 12 to 18 months, if you found somebody who had shown very few symptoms, who had antibodies, so had obviously had it but not suffered, would that lead you down a path more? Would you be more likely to be able to find the way of vaccinating against that from that person rather than somebody who's very ill?
No, I don't think we'd be sort of going there at the moment. I think the point about a vaccine, actually, there's remarkable progress being made about vaccines. I read today that in Washington they're starting a phase 1 trial on vaccines. I read the other day about phase 1 in Seattle, and I'm sure they're going. Trials are ongoing in China. That means that healthy volunteers are actually being given the vaccine at the moment. The problem with the vaccine is, are you sure that the bug isn't going to mutate? Are you sure that the vaccine isn't going to cause more problems? And all of that has to be ironed out first. So you're right, it's probably about another year away.
Not sure I would want to be that patient zero who was prepared to put themselves forward.
I'm just saying healthy volunteers, the healthy volunteers. That's how people develop vaccines. Yeah. They look for people who are willing to do that and go into clinical trials, and then you work out from the clinical trials. In terms of what you need the vaccine before you decide what policy. I mean, if you think about it, we give everybody the flu vaccine who needs it. We give it to kids, we give it to vulnerable elderly, and we don't wait to see if you've got the antibodies first.
Yeah, so perhaps you saw the article in the Sunday Times from a doctor used to dealing with pandemics who said the last thing he would want to take is a vaccine when it comes along. So everybody has a different opinion on that one. Yeah. Jeremy, in fact, all of you, this is a question that's been bugging me. What use is a virus? I mean, why are they there? What do they do? Jeremy, you first.
It's not the use is not for us. The use is for them. I mean, this is a chicken and an egg question. Why is there a chicken? Why, we're trying to imply a function for something that just exists.
Sian, are there any examples of useful viruses to mankind, man and womankind?
There are lots of organisms who can coexist with us without causing us any problems. And, maybe, I don't know what good they're doing, but I'm sure they're doing some good. But it's not a question I can easily answer at this time.
Yeah, so the fact is we know very little about them other than eventually how to beat them in battle. We don't know why they go to war in the first place. Don't we need to understand that?
Yeah, we could try to understand that.
You're either looking at me as though it's the most ridiculous question.
No, I'm not looking at you ridiculous. I'm just thinking, I hadn't thought of that one, but it's a bit like asking about the origins of life. It's sort of, they are a part of our life. They're a part of the universe. They're a part of what exists.
Yeah.
And we usually coexist perfectly okay alongside them. It's just when they become pathogenic, like this one has. This virus has been living probably in bats for forever, still living in bats, no problems for the bats, no problems for the civet cats who got SARS in the first place. And then when it comes to us,
So why is it, let me ask Jeremy this one, why is it that some viruses can exist quite happily without damaging the host, and yet as soon as they are exposed, I mean, it could be the pangolin, it could be a bat, it could be pigs, seafood, I don't actually know at the moment, but what is it that changes in them that makes them lethal?
So it's not necessarily that anything changes in a virus. So you might have a virus that has has a reservoir of, say a civet cat or bats, as we're finding very often. And in a lot of cases, the virus has evolved to coexist with the bat and maybe not necessarily cause much disease. But if this virus then transmits to a human, all of a sudden it's in a new host. It's working in different ways. Now, it's the same virus often, but human is very different from bat. And so the effect of the virus can be dramatically different. So sometimes the virus does change when it switches hosts, but in a lot of times, it's just the host that's changing. So the virus is doing the same thing, but we're responding very differently.
Bob, I don't know, the suggestion being here that perhaps we have to wait for a vaccine, despite the fact they're testing in the United States, maybe 12 to 18 months. Do you think that is probably the only way that we are going to get through this? Because there's suggestions that it'll dip down within the next 2 to 3 months, perhaps, but then come back again in the winter because, of course, not everybody's been infected and the virus is still out there. Have we got to wait for a vaccine to feel entirely safe?
I think the potential of a vaccine will offer us some degree of protection going forward in the future. Again, as was said earlier, it depends on how the virus mutates. Would it be something akin to the seasonal flu, where we have to devise and guess how best to treat the next year's coronavirus? So we may enter into that sort of a cycle. But as we need to be as prepared as possible and minimize the contagion.
Okay. Sian, and if we've got time, Jeremy, I'll come to you again in just a moment. 1917, 1918, Spanish flu, only called that because it was reported in the Spanish papers. But people were traveling to all corners of the globe at the end of the First World War. You have a similar situation here, where air travel, people just disappearing left, right, and centre around the globe, makes this similar in its own particular way. Now, I've seen a couple of things posted which suggest that what we're going to see is a return to older habits, because we don't want this sort of thing to happen again. That in fact, it might be a better world because there'll be less air travel, there'll be bluer skies, there's less pollution in China, etc., etc. Is this as apocalyptic as we think it might be, or is there perhaps a cloud with a silver lining here?
Well, I think part of the silver lining is the way communities are coming together. In our rural community here, we have set up a coronavirus help group, a help network. And so if people are self-isolating, unable to go out and get the milk or get the post or post a letter or just need some medication collected for them, and one of us in the community, a volunteer, will go and do it for them. And that is a good thing. Surely that's social connectivity and the networking and being aware of our neighbours. So I think that that is a bit of a silver lining. In terms of how will people travel in the future, I'm sure that because you can now see clear blue sky in Beijing all the time, not just when the factories are closed, it it sort of makes you think, doesn't it? It makes you think.
Absolutely. It does make you think. It makes you think. Each one of you, Jeremy, thank you very much indeed. You can have a say on this very quickly if you want to. Makes you think that there are things we've been ignoring that are very important.
Yes, maybe it's a good pause. I heard what the social historian Professor Hennessy say. We may be looking back at this century from BC before Corona and AC after Corona. So the AC period that we are moving into may be one that's more socially aware, more networked. Yeah. Works in a different way, lives in a different way, and maybe a better way.
And it gives us patience, because I had asked Jeremy that question and he was about to start. Sian, you replied wonderfully well, and Jeremy looked quite content with it. We are all calmer, better people, and I heard on the radio today that if anything comes out of this, it should be more kindness. You've just made the point. And very kind of each one of you to join us on Roundtable. Bob, Jeremy, Sian, thank you very much indeed. Thank you. Good luck with all of the work that you're doing on COVID-19 and other diseases that we have yet to describe. Thank you for coming on the programme. Thank you very much for watching this edition of Roundtable. I'm David Foster. From me and the team, we hope to have your company next time. Until then, goodbye.